cartoon that I've had for many years. It is Peanuts. Do you know this cartoon, Peanuts? Charlie Brown is saying that there is no greater burden than a wonderful potential. No heavier burden than a great potential. So you have given me very too much of a potential, Madame Burkholder. This is a very big challenge to think with you about these 2 days, because the presentations have been varied. They have covered a lot of area, a lot of ground, very interesting, going in a lot of directions. Before I start, I want to recognize two very important people who did not know what they were signing up for. Ms. Gillian Harkness and Ms. Mavi Lovetali thought they just got to accompany me. They did not know they had to translate everything for me. Would they please stand and would you please thank them? So I take full responsibility for what I understood, but I understand much more thanks to the two of them. So in thinking about what I might, how to pull things together, and you will hear many of the threads in the things that I am going to talk to you about now, of all of the different projects, many different threads. What I want to do is challenge you a bit, but mostly help you think about how you want to progress. There are many challenges involved in growing a differentiated level of nursing practice, and we are going to talk about how that proceeds. I have talked about these ideas of how specialties evolve to advanced practice nursing in at least 5 different countries. I did not create these ideas thinking about other countries. I created them thinking about the U.S. But it is very interesting to me that in the countries where I have presented some of these ideas, they have been useful for people who were in very different cultures. So I hope you will listen to these remarks with your own specialty development, where you are in your own thinking in mind. Use the ideas that are useful to you. Discard the rest kindly. First of all, you are doing a very complex and important thing at this conference, and I commend you for it. This is a not easy project. It is difficult to advance our discipline. We have a very long history of valuing a nurse is a nurse is a nurse. When we begin to say we are different from each other, it is a very big challenge to say, yes, but we are all valuable, but we do not all do the same things. We do not bring the same skills. We do not view our practice the same way. We ground it always in the core values. I loved what was said in the last summary. You have articulated over these 2 days some very important core values that we share with all nurses. We don't want to lose these things as we grow an understanding of advanced practice. Are you with me? Does this make sense? But the notion that we will begin to differentiate is part of what this movement toward an advanced level of nursing is about. It is a difficult thing. So it is important to be thoughtful, and that's exactly what you're doing. So I think that one of the interesting things about the symposia was, as the reports today and also the reports yesterday, you are sharing your successes and your challenges, and this helps everyone to grow in their thinking. So I commend you. So I'm going to think with you a little bit now about the future. And one of the things that I think is very important, and you have an advantage in some ways, is that there is now quite a past for advanced practice nursing. The origins of advanced practice nursing are over 100 years old. We can begin to see nurses growing their practice in the early 20th century, and this growth is accelerating around the world, and there is much that we can learn from the experience of other cultures and other nurses. It is also true that if we look at advanced practice in the United States, the first writings about advanced practice, the term advanced practice nursing, only started to be used in the 1980s. This is only 40, 30, how many years? 30 years ago. This is only a little over 30 years ago. This is not a very old idea. This is a pretty young idea if you think about the history of nursing. So it is important to take a long view. We have been growing toward this notion of advanced practice for a long time, but it is still a pretty young idea. Does this make sense? Yes, no? Yes. Oh. The second thing that is extremely important, the decisions you make now create your future. They plant the seeds of a direction for your future, so that it is very important to think about what is your preferred future. We did not always do this in the U.S. because we were regulated at the state level. We have many institutions in different states. Some are private, some are part of the state. They took different directions. There were many roles that took different directions. We did not always come to a coherent, unified vision. This slowed us down a lot. It had consequences for us. So you should learn from our mistakes. You should learn in ways that will be good for you. So I have heard three things today. I've heard the idea that maybe French-speaking nurses should come to a coherent vision of what they think advanced practice should be. I have heard that maybe that canton by canton, because within Switzerland there are big differences in the German-speaking part of Switzerland, those cantons, and the canton in the French-speaking part. So maybe it is better to have a vision by canton. Maybe it is better to have a Swiss vision. I think I do not know, minister, the lady talking this morning, Ms. Buff? I do not know directoire title, I don't know. But at any rate, she was talking about the federal regulation, but the federal regulation, from what I understood, is at the professional nurse, basic professional nurse level, not at the advanced level. So you have the opportunity to shape that in a regulatory way, to get involved with this policy, these policy discussions, and shape the direction it should go. So maybe that is the best preferred future. It is not for me to tell you your future. It is for you to say what it is. But to the extent that you come together in this future, I think you make faster progress. Does this make sense? Okay, so now you see many words that were already used many times today. This is a very strong conviction of mine, as you know, that if we want to grow ourselves as a respected profession and discipline, that we need to do it in a cohesive and proactive fashion. Too often in our history in the United States, we have been fragmented. We have not come together. We have been reactive. We have waited until things happened that we did not like. And then we said, we do not like this. And it's much harder to change something that's already done that you did not respond to than to respond early and shape the direction. And we have been haphazard. We have not started with a vision. I think that we are getting a more coherent vision about advanced practice. This is accelerating greatly in the last 10 years in the États-Unis, but we have still a way to go. Okay, I want to share with you a core idea I have that shapes the way I will talk about everything else. In the older view, I call it the older view because I think it is the historical view that all of healthcare was basically medical care, so that physicians were in charge of everything. Anything related to medicine was physicians driven. And that nurses did a little bit of what physicians do, and that advanced practice nurses did a little bit more of what physicians do. But do you see how, oh, is this wonderful pointer still around? Okay. You see how these two things are still within this big doctor thing, right? You see this? I think they got it. This is not really the reality. And part of what you have been talking about today in these various projects is the recognition that that is not the reality. And in fact, one of your physician colleagues who talked this morning stayed after to talk to me, and he was saying exactly this. He was saying this: I do not know how to do everything for my patients. I have to have nurses, I have to have physiotherapists, I have to have chaplains and social workers and occupational therapists in our country and respiratory therapists. I do not know all of your specialties. But we need all of these people to be able to do the very best job for the patient. Now, what this figure does not show, and I could not figure out how to make it show it, but I mean for it to be there, is the patient is in the middle of this, not the doctor. The patient is in the middle. So the notion that we are all trying to serve the patient is one important notion of this figure. Healthcare is bigger than any one discipline. So then also the other implication is we overlap with each other in our activities, in our responsibilities. We have an overlap. So it is not fair to say that nurses are completely different from physicians. In fact, we're going to talk about this interesting term, technology transfer. Do you know this term, technology transfer? You know, in the early years of the 19th century, or the 20th century, nurses could not do blood pressures. They could not take a blood pressure. Only a doctor could take a blood pressure. And then nurses could not draw blood. Only a doctor could draw blood. Then nurses could not intubate a patient. Only a doctor could do that. Now we have nurses who do all of those things. We take for granted. We have assistants who do who do blood pressures and draw blood. So we have transferred the technology. As the technology becomes established, it gets transferred among many disciplines. So this notion of technology transfer is always operating here as people are growing and as they are developing their skills. So you see that for an advanced practice nurse, there is growth in their skills and abilities in the medical domain in terms of diagnosis and prescribing and medical treatments. There is growth in domains shared with other disciplines, and there is growth within the larger healthcare arena itself. Does this make some sense to you? So what this means, whoops, oh dear, sweet pressing. Okay, what this means is here, that all providers contribute to the larger arena of healthcare. And when we say, well, what should that look like? That should look like a collaborative interprofessional team. So, yesterday in one of the symposia, one of the speakers said, well, how do I know if I have a good collaborative team? I said, this is how you know. These are the things that you see in a strong collaborative team. You see that every member of that team is competent in their discipline and accountable for the work they do. They do not try to blame somebody else. They take accountability for the work they do, and they are competent in their work. You do not build collaboration if you do not trust your other team members to be competent. So building our clinical competence is critically important. Second, we share a common purpose focused on the patient. I love the idea that it also is a common purpose focused on the leadership of the patient in helping guide us as a team to their better health. But this common purpose, this focus, gets teams past many disagreements. Thirdly, we know how to talk to each other. You cannot collaborate on a team where you cannot communicate. Yes, this is pretty basic, but it's amazing to me how many times we put up with very poor communication from other people on the team, instead of saying, we cannot grow together as a team unless we can talk to each other in an open and free way. If I am afraid all the time that I'm going to get in trouble, I cannot collaborate with you. I am too busy worrying about how not to get in trouble. I have to be able to communicate with you interpersonally. I have to be competent at that. We have had some situations in the place where I work now where literally we are saying to physicians, you must learn how to communicate better in a more open and free way, because we cannot afford for you to not have to be part of a healthy team, because your patients cannot get the best care. So interpersonal competence and effective communication is key in healthy collaboration. We have to trust each other. This is something you must build over time as people gain confidence in your skills and your communication and your work. I always used to say, when I was practicing clinical nursing, I used to say I hated to move to a new place because I wanted to walk into that place and say to all the doctors and all the other therapists, I am a really good nurse, let's get to work. It did not work. You cannot do that. You have to build trust. People have to grow to trust you. So when we have revolving doors, when people are leaving and turning over rapidly, when teams cannot coalesce and have any stability, this compromises collaboration because we do not build trust with each other. We must respect each other and recognize that we bring different things to the patient care. We bring complementary knowledge and skills to the patient care. And my last characteristic is that healthy collaborative teams laugh together. They have fun together. They make jokes with each other. Not hurtful jokes, but funny jokes. I always know that I am reaching collaboration with members of a team that I am working on when we start to laugh together. So when I think about these ideas about how do we begin to develop a specialty, and then how does that specialty evolve? Some specialties, as I said yesterday, evolve toward advanced practice nursing, and some specialties do not. And this is okay. Specialties evolve the way they need to evolve, given many factors. What we see is what we have identified, and what I have, as I said, shared in other places that has been helpful in people's thinking, is that there are 4 stages. So in this first stage, you see that specialties begin to develop as there's increasingly complex care demands, new technology, changes in the workforce, expanding practices. So I will just take oncology as an example. As we began to have more and more treatments, more complex treatments, more complex understandings of how to treat various cancers, we also began to grow this complexity in the technology and who could use it. We see this technology transfer begin to occur, where, for example, originally in oncology, only physicians could give chemotherapy. Now nurses give chemotherapy around the world. I'm sure you give chemotherapy here, yes? So this notion that the skills, the complex skills begin to spread out, begins to argue for a specialist base. In the early stages of specialties, they're not exclusively nursing. One of the very first nursing specialties was dietitians, dietetics. It spun off from nursing and became its very own specialty. But if you look in 1900 in the American Journal of Nursing, you will see dietetics listed as one of nursing's specialties. In stage 2, the specialty starts to get organized. This frequently happens informally. For example, oncology nurses began to come together to form an oncology society, an oncology nursing society, because they wanted to share their practices, they wanted to discuss their problems. They also began to say, we need some training in understanding some of the therapies that we are starting to use. We want to know more about how to care for these complicated patients with cancer. Usually this training, at least in the US and in many of the other countries I've seen, starts off within a hospital, starts off as an on-the-job training, where people build their skills by experience and by working as an apprentice with a more experienced nurse. Then this progresses to certificate level training. Still it's informal, it's not within formal educational institutions. It becomes more involved, but it usually has a very strong apprentice model. You also see people start to write about being an oncology nurse. What is the role of the nurse in this new specialty, this growing specialty of oncology? It may or may not involve expanded practice. It depends on the specialty. So what are the challenges in this stage as people begin to start to say, this specialty is growing and we are starting to think about different levels of expectation? Well, first of all, we have to figure out, what are we talking about? What are the roles within this specialty? What are the opportunities for practice within this specialty? How do we identify what those are? We have to identify what we think the person can do before we can identify the curriculum that they need educationally. What do they need to know to be able to do this expanded role? How do we begin to standardize and think about credentialing and certification? And then as we are beginning to differentiate, how do we value all nurses as we begin to differentiate? These are some of the major challenges of people in this stage 2, moving into stage 3. How do we best recognize existing providers even as we are moving into new expectations? So in this third stage, what we begin to see, and we started to see this really in the 1960s and 1970s in many nursing specialties in the US, was that as the knowledge base was growing, as more roles were being discussed and written about, there were articles that said, well, this is what an advanced practice nurse does with oncology patients. This is how it's different from what a professional nurse does with oncology patients. As we began to differentiate these things, as specialty leaders started calling for differentiated education, and there began to be pressures to standardize this. How was this going to be harmonized? How could we be sure that a nurse was gaining this additional knowledge and these skills to practice at this different level? You would see also pressures around moving this training into formal graduate educational settings. And that as nurses were doing more, particularly in the US where the states were regulating the practice of nurses, the individual states began to get interested in what were these nurses doing, what were these nurses in these expanded roles doing, and how did we need to regulate them. So there began to be questions about how should we regulate. So in some ways that was very reminiscent of what I was hearing this morning. Yes? So in thinking about, okay, what does constitute an advanced level of practice, I would submit to you there are 4 elements. The first element is you see differences in the direct clinical practice, and I will go over these characteristics, these key characteristics in APN practice. You also see practice in the core competencies that we talked about yesterday. You see job descriptions that reflect the core competencies and that expect an expanded practice and attach certain expectations to that practice in terms of authority for practice and accountability for this expanded practice. And you see titles that reflect the advanced practice expectation. One of the things that has been important as we have tried to understand advanced practice nursing over the 5 editions of our book is we have always gone back to the evidence. And these core characteristics have been seen repeatedly in studies of advanced practice nurses as part of what that practice looks like. This is part of what a differentiated practice should look like. First of all, using a holistic perspective. All nurses use a holistic perspective. I think it's an important thing that we educate all nurses to do. But in an advanced practice context, you see that holistic perspective really applied into treatment recommendations, into evaluations, into how one does the assessment. It's not just the patient and the family, it's also the context, it can be the community, it can be a variety of other considerations that are brought together. The second thing you see in advanced practice is therapeutic partnerships. This notion that the patient is partnered. The patient is a full partner in care. The patient is not someone we do something to. The patient is a partner with us in trying to move to a healthier place for them. You see expert clinical performance. There were some early studies done in the 1980s that used Patricia Benner's categories of expertise and studied advanced practice nurses to see that they were experts, and they were, but they also had additional things. They had additional competencies. You see the use of active reflecting in practice, reflection in action and on action. This is from the work of Schön. I don't know if you know this work, but the idea is that you are always consciously trying to grow the practice through reflection on what is working, what is not working. The use of evidence as a guide to practice is clearly visible in APN practices, and the use of different kinds, diverse strategies. People use non-pharmacologic strategies. Early studies of nurse practitioners showed they actually prescribed medications less and used other different kinds of approaches to help people manage and work with patients to manage their illnesses. In terms of the issues of titling, as I mentioned yesterday, there are very big issues, and I think this is something that you have to address in this stage. What are you going to call people? I had a wonderful colleague who's a lawyer. She said, "We have no idea what to call you because you call yourselves a million different things." She was right. We cannot have 50 titles for advanced practice nursing and expect that the lady in the grocery store in line to buy her milk is going to know what the heck we are talking about. We see titling language vary greatly from country to country. I think this is okay, but I think that within a country or within whatever system, integrated system you are trying to apply, there has to be common understandings of titles and what they mean. Because if the titles are confusing, the regulation becomes impossible and not helpful. It becomes too restrictive. We have watched this over and over in the United States. It becomes confusing to patients. It becomes confusing to institutions who don't want to employ a person when they don't know what the title means. So this issue of what we call ourselves and how we clarify a title clinical nurse specialist as over against an expert nurse clinician. These are 2 titles we use in the United States to differentiate the nurses who are very expert by experience from the nurses who have a master's or a doctoral degree in advanced practice nursing. It is okay. It doesn't matter, but it has to be clear. It has to be clear. Another thing that has to be wrestled with, I think all of these things are challenges to wrestle with, is this issue of level of educational preparation. This is a key component in the development of advanced practice roles in every country. We have a chapter in our book that looks at international preparation, and in the last 3 years, graduate level education is clearly becoming the international standard. Half of the countries that were surveyed in the latest IMPAPA meeting, which was held in 2012, found that 50% of the countries required a Master of Science degree to be able to be called nurse. But there are also other reasons. I think that one of the major issues that we had in nursing 50 years ago was the status of the nurse, and that went back to the fact that nursing was primarily female and primarily educated in hospitals, did not have any kind of degree. In our country, a college degree and advanced degrees confer status. This may not be true in Switzerland or France or Belgium, but it probably is. So the issue of saying, I want to work collaboratively with a physician if I do not have any kind of formal educational preparation compromises my ability to be seen as a full partner with a collaborative team. In fact, one of the reasons that we are moving to the Doctor of Nursing Practice degree in nursing is because our colleague disciplines have all moved to a professional doctorate. Pharmacists receive a pharmacy doctorate. Occupational therapists receive an occupational therapy doctorate. It's called OTD. Physical therapists receive a doctorate. Social workers receive a doctorate. Nursing was the only healthcare professional at the table that was not being educated at the doctoral level in our country. So we are moving to this doctoral level. It is controversial. Not everyone agrees with it, but it is part of what I call educational parity. Do you understand this concept of educational parity? It has a lot to do with how nursing is seen in terms of status and power and collaborative potential, at least in our country. But it's not also in our country. If you look internationally, you will see that, and this is a major issue that I have discussed with colleagues in the Middle East, in China, in Hong Kong, in Japan, in many countries, in Canada, that this issue of status of the nurse has been linked very strongly to educational level. So this is a thing that you must also wrestle with here. The other issue, a part of that, is the curricula themselves must value clinical practice and clinical experience. The issue of how we are a practice discipline, we grow expertise in learning more about theories and research, but we also grow expertise in practice, in gaining skills in practice. So our education for advanced practice nursing has changed quite dramatically over the past 30 years to emphasize supervised clinical practice experiences at the graduate level so that nurses are gaining this experience with high-functioning advanced practice nurses who clearly understand their roles. And in fact, in the Doctor of Nursing Practice program, the number of clinical hours students have to have is double what they have to have in a master's. From 500 hours of supervised clinical experience at the master's level to 1,000 hours at the Doctor of Nursing Practice level. So doing that work moves specialties that are advanced practice specialties. So for example, when I think I mentioned to you that there are specialties that evolve away from direct clinical practice, such as administration. If you look in the early years of nursing administration, many times the head nurse did a lot of direct clinical practice, but increasingly now administrators are removed from practice. I had a teacher once who was a director of nursing in a psychiatric hospital, and he took care of patients every day. I do not know any directors of nursing who take care of patients every day. So what we see in moving toward, if the specialty continues to move toward advanced practice, we see this maturity, we see a growing maturity, and we also see this very interesting thing that numbers of you have alluded to in your projects now, this growing interdisciplinarity, where advanced practice nurses are understood, they are a core part of the team, people know what they can expect from that practice, and they recognize and value that practice in a collaborative way. But also the team itself evolves to be a team with a shared knowledge base where everyone is working together to bring their different skills together to best help this particular patient, to best partner with this patient. And so we are seeing this stage 4 in more and more specialties in the US. For example, in diabetes, there is an interprofessional certification now for advanced diabetes management. So nutritionists who work with diabetic patients, nurses, physicians, many of the disciplines that work with those patients in these collaborative teams take this interprofessional certification. So you see this growing interdisciplinarity as the specialty becomes more mature. Again, it goes back to the larger figure. As the specialties are growing, they are working more and more together. So, if you say, yes, we wish to go forward with advanced practice and we wish to develop further the clinical nurse specialist role, and you say to me, what would tell us we are getting there? What are the outcomes? What should happen? These are the things that I see that should happen. In collaboration with a team, high-level advanced care is provided to the most complex patients and families. And the outcomes are measured so that we can see that we are getting good outcomes. So when I was a clinical nurse specialist, I probably only directly got involved with the very sickest patients. I did not take care of all the patients on the floor. I selected the patients who I knew needed the skills I had. And I helped those patients manage their own care. I helped them get safely home. I worked with the home nurses who did not know how to take care of some of these very complicated patients, particularly the high quadriplegics. And I did all of those things in a way that was, that I could measure how whether they came back in the hospital, what kinds of complications they had, what they knew about their injuries, how they were able to return to work, how they were able to gain a good quality of life. You also should see that nursing staff are supported, guided, and developed so that the overall quality of nursing care in the areas where the clinical nurse specialist is responsible for the quality of care improves. And that recurring problems that indicate issues with the larger system begin to be recognized and addressed. It isn't about the individual patient, it is about the population and the structure in which care is given. This is part of what you buy when you buy a clinical specialist. Speaking from an administrative point of view, you buy someone who can look at system problems and begin to address them and begin to help you make changes to systems that improves the care that is being given to patients. If you say, what are the expected outcomes for primary care nurse practitioners? These are what I think are 4 key outcomes. The first is access to care for underserved and vulnerable populations, particularly people in rural areas, particularly people with inadequate incomes or very complex chronic illnesses who lack the resources to manage those problems, that primary care nurse practitioners can expand access for those patients. This is a major issue in our country where we have had many people with inadequate insurance or no insurance, and now we are going to begin insuring them, and we think that we will have 34 million more people coming into our system. And the issue is who will be taking care of those patients. Primary care nurse practitioners, as I said, can manage the vast majority of primary care needs in a very cost-efficient way. So you see the second one is cost-efficient primary care. That means we measure the costs of the care that we give so that we can see how expensive it is compared to other kinds of costs. Holistic perspective and health promotion are key focus areas for nurse practitioners, and that we begin to see more attention given to health promotion and health prevention. This is an absolute imperative in our society because many of the chronic illnesses we have are illnesses of lifestyle. Obesity, diabetes, lung problems are all from lifestyle choices, smoking, overeating, etc., which I'm in grave danger of here. Actually, your food is quite delicious. And you also should see stronger partnerships between professionals, patients, and communities. Nurse practitioners in primary care are very educated to be looking at the community and the patient in the context of the community, the patient and family in the community. So you are building stronger relationships between communities and people and healthcare providers. Let me say a word about the cloud. Numbers of you talked about the cloud yesterday. The cloud, of course, is these critical environmental elements, and thank you for calling it a cloud. Some of you did call it a Friday, I got you to notice this. These elements are all things that must be attended to to get to stage 4. They are complicated, they are difficult. The issue of how advanced providers are seen by policymakers and how clear you can be about why this level of nursing is needed and valued and how it should be facilitated through regulations is a very important part of growing into stage 4 and maturing this. We have worked very, very hard at this in the U.S., really since the 80s, 70s and 80s. And we now have a national model that we are looking to implement in every state that allows nursing, advanced nurses to access patients in every state without a lot of barriers. This has taken a very long time, and it also took us coming together. But we are getting there. So all of these things, the structure and organization, we must have titles, we must have job descriptions that allow this practice. It doesn't help to educate people and then not allow them to practice. It doesn't help to put people in practices that they are not properly educated for. Either one of those situations leads to a failure of advanced practice nursing. So in all of these ways, marketing and being clear about what are these advanced practice titles that we are growing toward and what is it they offer to patients and families and healthcare teams. What kind of outcomes can you expect when you hire an advanced practice nurse? What kind of job description do you need when you hire an advanced practice nurse? How are you going to pay this person for this expanded work? Numbers of the projects have raised the issue of financing and sustainability. These are very, very big issues. We did some of the early work on sustainability through getting grants from healthcare foundations. Then we began to get agreements from insurance companies that they would pay for the level of practice because they could see that that would save them money in the long run. So there are many ways that you start thinking about sustainability as you are trying to grow the practice. But these are also very important considerations because the core needs to be healthy, but it has to be able to work in the environment. And I think that is one of the big challenges in growing from stage 1 to stage 4. You have to be consolidating the core and understanding what this level of nursing is, but you also have to be thinking about what is happening in your context, the policy context, the organizational context, the healthcare financing context. All of that has to be factored into the discussions. I think that many of you that are doing these very innovative practices, I really hope you are tracking costs. I like to say to my students that money is the bottom line, it's the top line, it's all the lines in between. You are either saving money or you are making money. If you keep a patient from having a complication, you are saving money if you were in a hospital or at home. If you manage a care There was one project that one of my colleagues did. She saved over $1 million in a year. She saved over $7 million in 5 years with a special project that she managed. Nobody ever wanted to take her job away. They wanted more of her because she was saving money. So I think the issue of saving money or making money, there are things you have to pay attention to. I never liked to think about money when I was a young nurse. I thought it was kind of icky. But in advanced practice, if we want to grow and sustain these things, we do have to think about this. So I want to leave you with the final thing. About 15 years ago, I guess now, the wound ostomy continence specialty was at a crossroads of deciding whether they were going to require advanced practice nursing at the master's level to be able to be considered a full-fledged wound ostomy continence nurse. They were trying to grow educational programs. They were moving beyond their earlier beginnings as intrastomal therapy only. And they asked me to review all of the papers in an issue on wound ostomy continence nursing and write an editorial. So I did write that editorial. I was very impressed with what they were trying to do. I talked about some of the things that I've talked to you about in that, and this is how I ended with them. I said, what will history say about you? So one of the things as you move forward with this very ambitious and very wonderful project is to think, in 50 years, what will history say about us? My hope is that they will say that you clearly saw patients' needs. Very impressive that you are seeing your patients' needs in the way you are. This is very impressive. This has always been a good strength of nursing. And you developed your skills to meet these needs. As our patients' needs change, we adapt as well. As the knowledge base grows, we grow as well. As the therapeutics grow, we grow as well. So, that you are seeing these needs and developing your skills, that you grasp the role opportunities that were possible and that you created new ones. And that most importantly, you move forward together. Thank you.